Now I invite Dr. Sandhya to give her talk on dealing with small pupil. Dr. Sandhya is a senior consultant cataract at Giridhara Hospital, Edappally. Over to you, Sandhya.
So my topic is dealing with the small pupil. So there is no generalized consensus on the size of the pupil below which phacoemulsification is unsafe. So for most of the experienced surgeons, a threshold pupil size of around 4.5 to 5 millimeter is enough for safe phacoemulsification. So what are the challenges of small pupil? A small pupil can impair visualization of the anterior lens capsule, resulting in a small rhexis, which in turn can lead to difficulty in pulling out the nuclear fragments in case of phacoemulsification, and also getting out the whole nucleus from the bag in small incision cataract surgery. Also, when the rhexis is small, there is increased risk of damage to the rhexis margin, and which can go beyond the equator and can produce a wraparound tear of the posterior capsule. There is also increased chance of retention of cortex and nuclear pieces in the bag, and suboptimal visualization can cause difficulty in placing the intraocular lens inside the bag. So because of more manipulations, there is increased release of prostaglandins, which can exacerbate the postoperative inflammation and cystoid macular edema. So pupil can be expanded pharmacologically or by mechanical methods like viscomydriasis, synecholysis, pupil stretching, sphincterotomies, or by the use of pupil expansion devices. So preoperative use of NSAIDs can sustain pupillary dilatation and can also reduce the incidence of intraoperative meiosis. Combination of cycloplegics like tropicamide and adrenergic receptor agonists like phenylephrine and adrenaline can be injected intracamerally to dilate the pupil. Combined intracameral use of mydriatic and local anesthetics like preservative-free 1% xylocaine can be used in topical anesthesia. So in this patient, intracameral adrenaline was used to dilate the pupil. And then a high molecular weight OVD was injected in the anterior chamber and also within the pupillary margin to cause dilatation of the pupil and deepening of the anterior chamber. So in this patient, if the pupil is not very small, you can get an adequate size rhexis even without the use of pupil expansion devices. Here 2 to 3 strokes of the rhexis can be taken out, and then you have to bring the apex of the rhexis within the pupillary area, and then again take 2 to 3 strokes outside and then bring it within the pupillary area. So we always should bring the apex within the pupillary area in between, because with continued force outwards, the rhexis can extend to the periphery. So this should not be attempted if the pupil is very small and if the lens is intumescent, and also if there are features of IFIS. So what are the prerequisites for pupil stretch and use of expansion devices? So maximum preoperative pharmacological dilatation should be attained. Anterior chamber should be filled with OVD to maintain AC depth and pupillary dilatation. Any synecdoche and pupillary membrane should be released. And very small and rigid pupil should be stretched before using these expansion devices. So in this patient, there was an organized membrane covering the entire pupillary area, and there were posterior synecdoche. So there was a gap between the iris and the organized membrane through which a thin iris repositor was introduced, and the organized membrane was released from the pupillary margin. And then OVD was injected under this membrane, and from the other side port, rest of the synecdoche and pupillary membrane were released. Now there is a thick band there which could not be released, and it was cut by using microrhexis scissors. So once all the synecdoche and the membrane were released, iris hooks were used to expand the pupil, and then phaco was completed. Now in this patient, mechanical stretching of the pupil was done. So anterior chamber was filled with OVD, and 2 Coughlin hooks were introduced, and the iris was stretched diagonally. Now the aim is to produce micro tears at the pupillary margin, sphincter tears at the pupillary margin, but you should apply uniform force and should not stretch the iris too much, because that can cause tearing of the iris. So this is useful in case of post-UVT cataract and also in rigid pupil. Also, while taking out these Coughlin hooks from this area, that is the extreme periphery, you should take care not to cause DM detachment. And this is applicable in many cases, and it is relatively simple. And in this patient with black cataract, where a small incision cataract surgery was done, Iris hooks were used to cause pupillary dilatation. So whenever you are using trypan blue in case of small pupil, it is better to go under the iris and inject trypan so that it will stain the periphery of the capsule and you will have a good visualization later when the pupil expansion devices are used. You should also irrigate excess of trypan blue so that it doesn't leak out from behind the iris and obscure the view when rhexis is made. So 4 equidistant paracenteses were made here. That is, you should make these paracenteses at the posterior limbus and they should not have a long corneal tunnel, because in that case it will cause stenting of the iris and then the manipulations will become difficult. So these iris hooks have got a silicone sleeve, so that should be retracted and it is inserted inside the eye and the iris is hooked. Once it is hooked, you can tighten the sleeve. So after insertion of the first hook, subsequent hooks insertion are easy because the iris is already lifted up from the anterior lens capsule. You can also inject little OVD under the iris margin so that there is space between the anterior lens capsule and the iris. Then you can adjust the size of this pupil by further tightening or loosening the sleeve at the end. Here the cataract is black and it has a huge nucleus. So we want a really large rhexis here. So a very large rhexis was made and then a large scleral tunnel, that is 1.5 millimeter from the limbus, was also made. And here the entire nucleus has solidified. So while doing hydrodissection, it was very difficult to insinuate the cannula between the capsule and the cataract. So hydrodissection was done by injecting small amount of fluid at multiple places. And after a good hydrodissection, the upper 2 hooks were released before the nucleus was taken out. So you have to retract the silicone sleeve and make the hook parallel to the iris and then take it out. Nucleus rotation was ensured, and then using 2 Sinskey hook, the nucleus was taken out of the bag. The left hand Sinskey hook is going under the nucleus and it is retracting the rhexis, because there is high chance of bag also coming out along with this large black cataract. So the lower Sinskey hook was used to retract the rhexis margin, and then the nucleus was taken inside the anterior chamber and then using traction counter traction method it was delivered. Then after IOL insertion, before taking the OVD, we need to remove these hooks, and then pilocarpine was injected. Now this is Malugin ring is a square shaped deicide made of polypropylene, and it has got 4 scrolls, and this comes in a preloaded manner and it can be withdrawn into the injector. Now after filling the all these devices should be inserted after nicely filling the anterior chamber with OVD. The distal and the 2 side scrolls got engaged at the time of insertion itself, and these can be inserted through even 2 millimeter corneal incisions, and the proximal scroll was engaged using a Sinskey hook. Now this Malugin ring, it produces a round shaped pupil because it has got 8 points of contact, 4 at the regions of scrolls and 4 in between these scrolls. So it produces a pupillary dilatation of around 6 millimeter, which is adequate for most of the phaco cases. Then these are relatively stable rings, and usually it doesn't hinder with our surgical manipulations, and it doesn't get dislodged very easily. So one more thing is that it's available in 2 sizes, that is 6.25 and 7. Now when we are using these rings, it is very important to chop down the nucleus into multiple smaller pieces so that it can be pulled out of the bag without disturbing or dislodging these rings. So if it is very large piece, then while pulling out, you can disturb the ring. So a lens was injected, and this ring, the scrolls were disengaged from the pupillary margin using the Sinskey hook. This should be done before removing the OVD, and it was totally freed and kept in the anterior chamber. And using the same injector, it can be withdrawn. So you have to hook it like this and then pull it into the injector. You can use an iris repositor to guide the retrieval. And then usually these rings do not damage the sphincters. So at the end, you will get a near normal pupil. So this is B-hex ring. It is a uniplanar hexagonal ring. It has got 6 flanges on the sides and 6 notches. Then alternate flanges have got holes in it. So after filling the chamber with OVD, there is a specialized 23 gauge forceps for inserting it. The B-hex hooks can be inserted through with that forceps. And then the flange with the hole is carefully placed under the iris, simultaneously taking care to hook the 2 notches also at the pupillary margin simultaneously. And if you want to release it, you can use an iris repositor also. And the last flange can be placed under the iris through the same paracentesis, or you can approach it through the opposite paracentesis. You can use the same 23 gauge forces also for this manipulation also. And this gives an pupillary dilatation of around 5.5 millimeter. And since these rings are, have a vertical thickness of only 0.1 millimeter, it can be used even in in patients with relatively shallow anterior chamber also. And it can be inserted even through side ports with 1 millimeter size. And then after nucleus emulsification, cortex removal was done. And then using the Sinskey hook, these rings were released from the pupillary margin. You may get some pigment dispersion, mild pigment dispersion, when you are taking out this hook from the pupillary margin. And then it is very flexible, and you can just take it out through the incision like this. Now in this patient with small pupil, Inova ring was used. This Inova ring is a silicone ring that is from Orolab, and it's a circular ring, and it has got groove on the side for uniform expansion of the pupil, and also it has got 4 positioning hole, and these should be engaged at the pupillary margin. It comes in a preloaded form, and you have to just got 2 holes, one here, 1 hole, and through that OVD can be injected. And then after like IOL insertion, this can be injected into the anterior chamber. When almost 3/4 of the ring is inside the anterior chamber, it can be pulled out, simultaneously withdrawing the injector. So this is a relatively bulky device compared to other devices, but gives a larger pupillary dilatation of around 6.3 millimeter. So then these positioning holes should be carefully engaged at the iris margin using the Sinskey hook. And so you will get a relatively larger rhexis when we are using these. But since this is bulky, so when you are introducing your phaco probe and all, there is a slight possibility of disengagement of this ring. So after then lens removal, the ring was disengaged, and then you have to keep the iris repositor beneath, and then a Sinskey hook can be placed in that positioning hole, and then just withdraw it from the anterior chamber. So compared to hooks, all these devices will give a relatively physiological pupil at the end, because damage to the sphincter is minimal with these devices. So to summarize, we have various options to expand the small pupil during cataract surgery, and choosing the appropriate device in different clinical scenarios will give optimal outcome. Thank you.
Thank you, Dr. Sandhya, for clearly explaining the principles to use during small